The urinary system is interconnected with all other body systems. For instance, the kidneys and skin both play an important role in the production of the active form of vitamin D. The kidneys are going to work together with osseous connective tissue to help control blood levels of calcium. The muscle tissue helps control the elimination of urine from the urinary bladder. Our nervous system is going to influence production and elimination of urine. Our endocrine system is going to influence the production of urine. The cardiovascular system helps to regulate blood volume and blood pressure in conjunction with the urinary system. The lymphatic system is involved because the kidneys control extracellular fluid volume and composition, including lymph. And the kidneys can also compensate for fluids lost by the digestive system. The kidneys work together with the lungs to help control the level of pH in our internal environment. And the urinary system in males shares common organs with the reproductive system, and kidneys can also compensate for fluid lost from the male and female reproductive systems. So everything is interconnected. The body does not function in separate little different silos. The urinary system is really important because it helps control the composition of our internal environment. What are some of the important functions of the kidneys? Well, the kidneys help regulate the total volume of water as well as the concentration of solutes in fluid, which is osmolality. They also regulate electrolyte concentrations in extracellular fluid. They assist with long-term acid-base balance. They also help excrete metabolic waste and foreign substances in the form of drugs and urochrome and toxins. They produce a hormone known as erythropoietin, which helps regulate the concentration and numbers of erythrocytes. They produce the hormone renin, which helps secrete aldosterone. They convert vitamin D to its active form, and they also help carry out gluconeogenesis during prolonged fasting. If an individual experiences kidney failure, that can result in weakness, lethargy, shortness of breath, anemia, edema, metabolic acidosis, and heart arrhythmia. Most people understand that the kidneys produce urine. There are functional units within the kidneys known as nephrons. Books vary on the numbers of nephrons in each kidney. A lot of resources say that there's approximately 1.25 to 1.5 million nephrons in each kidney. And as blood flows through these nephrons, the plasma and the constituents of blood plasma gets filtered out through the nephrons to become potential urine. As this occurs, 99% of the water in the filtrate is going to be reabsorbed, which is really important because if we lost too much body fluid, then we wouldn't have enough blood pressure and organs would shut down. So it's important that we reabsorb that much water back into the bloodstream. Urine composition can vary from day to day depending on dietary intake, water intake, exercise, metabolism, infections, environmental temperature, and medications. The normal constituents of urine, besides water, are going to include things like nitrogenous waste products, which would include urea, uric acid, and creatinine, electrolytes like sodium chloride, sulfates, phosphates, pigment from bile compounds, foods, and drugs. A urinalysis performed with a chemstrip is a quick and easy method to determine whether or not there's potential kidney disease. For instance, a chemstrip can detect excessive proteins, which could indicate possible kidney damage. It can also indicate whether or not there are excessive sugar molecules, which could indicate diabetes. Color changes can also indicate problems. They may be due to the breakdown of products of erythrocyte destruction, where a person might have an elevated urochrome, or changes could be due to liver disease, obstructions, cancers, kidney stones, dehydration. The chart on this slide is kind of cute because they show the color purple, and underneath that it says there's no such thing as purple urine, which is true. There is no such thing as purple urine, so I don't know why they included that. But there's some interesting information on here. Usually normal urine appears a pale straw color. If it's clear, it might be that a person is actually drinking too much water, but there are, again, resources will vary on the difference between absolute clear water and pale straw colored water. If a person has darker urine, and usually urine is a darker color in the morning because most people don't drink throughout the night, that amber color or honey colored urine indicates that a person does need to drink more water. That's normal in the beginning of the day for most people. It should not persist, though, throughout the day. The normal volume of urine that a person produces is approximately 1 to 2 liters per day. There's a saying, input should equal output. And if a person is experiencing diabetes, drinks too much caffeine or alcohol, has kidney disease, is using diuretics, or has sickle cell anemia, or simply drinking too much water, that could potentially lead to a condition known as polyuria. Polyuria is putting out more than 2.5 liters a day. Oliguria, on the other hand, is scanty urine. Oligo means scanty. So if a person is dehydrated or has had a lot of blood loss, has had diarrhea, cardiogenic shock, or kidney disease, that can lead to oliguria, which is an output of anywhere between 300 and 500 milliliters per day. Finally, anuria means there's no or virtually no output of urine, and that usually indicates either obstruction or kidney failure, and that's when a person is putting out less than 50 milliliters of urine a day. The pH of urine can vary depending on an individual's diet. The specific gravity, which is the measure of the amount of solute in urine, is going to be slightly higher than water. Again, because people don't drink during the night, specific gravity of urine is usually higher in the morning, but it really shouldn't be too much higher than water. If leukocytes are found in urine, that could indicate a urinary tract infection. Ketones in urine are usually suggestive of the metabolism or breakdown of fats and proteins, which would indicate a deficiency of carbohydrates. And it is abnormal to find blood, nitrites, glucose, and ketones in urine. We know that the kidneys produce urine, and urine has to travel to the urinary bladder to be stored until an individual can find a place to relieve himself. So the kidney has a special area called the renal pelvis, and the renal pelvis is going to have urine go into it. An extension off the renal pelvis is a tube-like structure known as the ureter. And so we can see that word ureter right here. It's that tube in yellow coming down towards the urinary bladder. We can also see the ureter here in this lower picture. The ureters open up at the base of the urinary bladder. You can see there's a ureteral orifice, which is an opening, and the base of the bladder has a special area that looks triangular, and that is known as the trigone. The trigone does not stretch and expand like the urinary bladder does. And so the urinary bladder is known as an organ that is retroperitoneal, so it's behind the peritoneum of the intestines. It is highly stretchable or distensible, and the smooth muscle that makes up the wall of the urinary bladder is referred to as the detrusor muscle. The inner lining of the urinary bladder is lined with transitional epithelium, and the process of urination is referred to as micturition. And there is a threshold of 150 milliliters of urine that can exist in the urinary bladder prior to stretch receptors sending signals that the bladder is starting to fill. Now, exiting from the urinary bladder is the urethra, which is going to transport waste outside of the body and is protected by surrounding tissues. The urethra starts at the base of the urinary bladder, where there is an internal urethral sphincter muscle, which is a circular sphincter muscle made out of smooth muscle, so it's involuntary. And from that point is where we find the urethra. So again, the urethra itself is protected by surrounding tissues. I don't know why this says it protects surrounding tissues. It doesn't protect any surrounding tissues, but it is protected by surrounding tissues. And it's the only urologic organ that is different between males and females, simply because the urethra in a female is approximately 4 centimeters long. In males, it's roughly 8 to 10 centimeters in length. So that's why females tend to be more prone to getting urinary tract infections, because there's not a lot of distance that urine can wash out the urethra to help cleanse it in a female as opposed to a male. Another reason females are more prone to urinary tract infections is because the area between the urethral orifice, the external urethral orifice, and the opening for the anus, the distance in the peritoneum is much shorter in females. And so it's closer in females than it is with males. So females are more prone to having bacteria get to the urethral orifice. Let's take a quick look at the micturition reflex. It begins when the urinary bladder begins stretching at about 150 milliliters of urine. When that level is reached, the stretch receptors in the wall of the urinary bladder are going to send information by way of sensory afferent nerve fibers to the sacral area of the spinal cord. So we have afferent nerve fibers by way of pelvic nerves that go to the sacral area of the spinal cord, and then the parasympathetic preganglionic motor neurons in pelvic nerves are going to carry motor commands back to the postganglionic neurons that are intramural neurons in the wall of the urinary bladder that are going to do two things. They come to the wall of the urinary bladder, and there are also neurons that are not shown here at the internal urethral sphincter. So right here, we've got two things that are going to happen. One is that the urinary bladder is going to start contracting in response to the filling, but we're also going to see a relaxation of the internal urethral sphincter. Now, the external urethral sphincter is under voluntary control, so we can hold that shut until the appropriate time. So this is the micturition reflex, where we have stretch and then reflexive contraction. And as the urinary bladder stretches more and more, there's going to be a stronger reflexive contraction knocking on the brain going, hey, it's filling, you need to find a bathroom. So as the stretch receptors are involved in that reflex, what you might not be able to see here really easily unless you look closely is that there's also information that's going to be carried along an interneuron in the sacral area of the spinal cord that goes all the way up to the thalamus, because remember the thalamus is the gateway for incoming sensory information. So it goes to the thalamus, it synapses in the thalamus with a neuron that's going to take that information to the cerebral cortex. And then the cerebral cortex, when the time is right, can send motor information back down to the external urethral sphincter to allow it to relax so that urine can exit the urinary bladder, and that's how urination occurs. Now, I'm not quite sure how the slides got mixed up, but that's okay. Either way, let's talk about ureters again. Remember, they are extensions off of the renal pelvis. They're tubes that carry urine from the kidneys to the urinary bladder. They are lined with smooth muscle, and you can see that beautiful smooth muscle layer in the bottom picture here. And they're also lined with transitional epithelium, and they do have goblet cells. The goblet cells produce mucus, which helps the urine pass through the lumen of the ureters. Now, the ureters actually go through peristalsis. That means if you were to stand on your head, urine could still get from your kidneys to your urinary bladder. That also helps to keep urine flowing in one direction so that there's no backwash or reflux. Now, that's how things normally work. However, there is a possibility that if a person has a really bad urinary tract infection, that it can go from the urethra to the urinary bladder, and the bacteria can climb up the walls of the ureters and get to the kidneys. That's when a person has, again, a really bad urinary tract infection, and they call that an ascending route of infection. It can happen, it's not common, but it can happen, and when it can, usually the person is in pretty bad shape. I know it actually happened to me one year. As we see, the smooth muscle layer is circular smooth muscle. Another thing that can happen is if a person forms kidney stones. Calcium oxalate stones are the most common type of kidney stone, and they're very jagged. So if they are going through the kidneys or from the kidneys through the ureters, they can sometimes jag through the transitional epithelium, irritating the smooth muscle, at which point it kind of clamps down on that kidney stone and keeps it from passing, which can cause obstruction and a lot of pain. So again, ureters go from the renal pelvis of the kidneys down to the urinary bladder. There is a little physiological sphincter when they get to the bladder at the area of the trigone. If we were to follow the production of urine as it travels through all the other structures to exit the body, that process includes first the nephron, then that urine will go into a collecting duct, which leads to a tube referred to as a minor calyx, which goes to a major calyx, and then from the major calyx, the urine enters the renal pelvis, which extends in the form of a ureter, which goes to the urinary bladder, and then finally exits the body through the urethra. When we look at the gross anatomy of the kidneys, we find that they're located between the levels of T12 and L3. They are retroperitoneal, so they're very close to the back. Externally, they have an outer layer that forms a connective tissue capsule. It's dense irregular connective tissue. They also have a thin layer of fat called the perirenal fat pad. There are adrenal glands located on the superior aspect of the kidneys, and that's why the adrenal glands are sometimes referred to as suprarenal glands. Supra means above, renal pertaining to the kidneys. There is an indented medial aspect of the kidneys where blood vessels and nerves enter and exit, and that makes up the renal hilum. Internally, there is an outer portion of the kidneys referred to as the cortex, and an inner region referred to as the medullary region or the renal medulla. The kidneys are like many other organs in the body. They have a cortex and a medulla, just like M&Ms have an outer candy coating shell and an inner chocolate part. The tissue of the cortex actually dives into the medullary region, forming columns known as renal columns. Within the renal medulla, we find structures that are shaped like pyramids, and these are the renal pyramids. Each renal pyramid ends in a nipple-like projection, and that is a renal papilla. There are approximately 8 renal pyramids in kidneys. It varies. 8 is the usual number, but it can be 7 to 10. But usually we find approximately 8 renal pyramids within the medullary region of kidneys. Again, each one ends in a renal papilla, which is a nipple-like projection, and the combination of the pyramids with the columns help divide the kidneys into areas known as lobes. Now, the renal papillae will be the area where urine is going to exit into structures known as minor calyces. Minor calyces lead to several major calyces. The major calyces are going to expand to form the renal pelvis, which is this larger area, and then the renal pelvis will extend further to form the ureter. And all the calyces, the renal pelvis, and the ureters have a wall that has smooth muscle tissue in it. So again, I've been using my hand to kind of try to demonstrate 3 major calyces. Here's one, here's another. I have problems separating my fingers, I know. And then the palm of my hand would represent the renal pelvis, and then my arm would be the ureter. Because blood filters through the kidneys 24 hours a day, 7 days a week, we're going to talk about the blood supply to the kidneys next. Understand that renal arteries, going each one to the right and left kidney, there's one going off in each direction, those are coming off of the aorta, and they'll deliver approximately a quarter of the cardiac output and will process roughly 1,200 milliliters of blood every minute. Each renal artery is going to branch off into 5 segmental arteries. We can see that those segmental arteries are going to be pictured coming off here. So we have a segmental artery here, and then there's another one over here. So 5 segmental arteries. The segmental arteries will further branch off into interlobar arteries. That's marked over here. And here's another interlobar artery that I'm going to draw an arrow to. The interlobar arteries are then going to arc over the outer aspect of each renal pyramid, and that's why we see arcuate arteries. That's how they got their name, because they arc over the outer aspect of the renal pyramids. Then they further branch out into cortical radiate arteries. And the cortical radiate arteries are going to lead to an afferent arteriole, which takes blood into the filtering area of the nephron, which is where we see the glomerular capillaries, or the glomerulus. From the glomerulus, blood will exit through an efferent arteriole. This is the only place in the body where we have afferent and efferent arterioles. From there, blood will flow through peritubular capillaries, or the vasa recta, and then blood will then go through cortical radiate veins and arcuate veins. The blood then goes through interlobar veins. And then you'll notice that there are no segmental veins in the exit of blood from the kidneys. From interlobar veins, we go right into renal veins and then into the inferior vena cava. Next, we're going to take a closer look at nephrons and the vessels associated with them. Books say different things in terms of the numbers of nephrons, so please don't get caught up in that minutia. Some resources say 1 million to 1.25 million, some say 1.25 million to 1.5 million. There's over 1 million. Nephrons are the functional units of the kidneys, and part of the nephron is referred to as the renal corpuscle. The renal corpuscle is the area of the nephron where we have blood entering in by way of an afferent arteriole to this structure here, which is known as the renal corpuscle. The renal corpuscle is a combination of the glomerulus, which is a special tuft of a capillary that's kind of twisted inside. Well, it's not twisted, it's just folded up to make more surface area inside a special capsule known as Bowman's capsule. And what happens is, as blood flows through the glomerulus, it's under high pressure to force some of the plasma fluid out of the blood into the space of the capsule surrounding the glomerulus. And that plasma that filters out, that fluid that filters out, is not just water from the plasma, it also contains solutes based on the size of the particle that's being filtered. So we call that fluid filtrate. And the filtrate from the blood enters into the capsular space. The capsule is known as the glomerular capsule, or Bowman's capsule. Now, Bowman's capsule will continue in a network of tubules. The first tubule is called the proximal convoluted tubule because it's got these little turns and convolutions, and it's proximal because it's closest to the glomerulus. Okay, so the glomerulus is the actual capillary inside the renal corpuscle, and then Bowman's capsule is surrounding that glomerulus. There's a space between the capillary and the capsule where filtrate enters, and then that filtrate will continue as it exits Bowman's capsule into the proximal convoluted tubule first. Now, the proximal convoluted tubule will continue to extend inward, and it will extend down into what's referred to as the loop of Henle. And the loop of Henle, it's going in this direction. You can see these black arrows are much better drawn than my purple ones. So we've got the filtrate extending downward into this tube that's going to form a loop. And there's a thin portion that descends. That's the thin loop of Henle. And then there's a thicker portion of the loop of Henle that is ascending. So that's the thick ascending loop. You can see it going in the opposite direction. And then that thick ascending loop will lead to the distal convoluted tubule. The distal convoluted tubule will empty into this structure here, which is the collecting duct. And the collecting ducts eventually lead to the renal papillae. The renal papillae empty into the minor calyx, which leads to the major calyx, which goes to the renal pelvis. Now, you'll notice that different things are reabsorbed in different areas of these tubules. And you'll notice that there's a network of blood vessels that surrounds these tubules. That's because after blood flows through the glomerulus, there still needs to be some mechanism to recapture solute that we don't necessarily want to lose in urine. And there also has to be a way to get rid of things that we might still have too much of in blood. Like maybe we want to kick out some extra hydrogen ions. So the exchange is going to occur between blood vessels and these tubules, and sometimes things can even be changed at the point of the collecting ducts. So we'll take a closer look as we go along, but I want to point out while we're here that in the proximal convoluted tubule you see resorption of glucose, water, amino acids, and sodium chloride. In the distal convoluted tubule, we can resorb water. In the thick ascending limb of the loop of Henle, we reabsorb sodium chloride. And in the collecting ducts, we can reabsorb water when there is antidiuretic hormone present. Okay? Normally we don't pull water back into the body from the collecting ducts if there's no antidiuretic hormone. But remember, antidiuretic hormone means don't pee. So antidiuretic hormone would actually cause fluid to leave the collecting ducts and go back into the blood vessels. And then in the loop of Henle, that's where we reabsorb water in certain portions, and that's going to be different depending on where we are. So we're going to take a closer look at this, but I kind of want to get you thinking about where things occur because we're going to see this again. If we look at the physical presentation of the actual kidney as an organ itself, the renal cortex is lighter in color than the medullary portion of the kidney because it has more proximal convoluted tubules and distal convoluted tubules, and the cortical nephrons also have a shorter loop of Henle than do juxtamedullary nephrons. So what's the difference between the two? Well, here's a cortical nephron. Most of the structures are located in the cortex of the kidney. And the term juxtamedullary, which you see that term right here, okay, juxtamedullary means next to, juxta means next to. So here's a juxtamedullary nephron, and you can see this has a much longer loop of Henle. That actually allows the kidneys to concentrate our urine to a greater degree because the medullary area of the kidney tends to have more solute. A higher osmolarity means more solute, and so it tends to help pull water out of this loop of Henle before it becomes more urine. We can only concentrate our urine to a certain degree, but having this higher area of osmolarity helps to concentrate urine. As urine is produced from blood filtrate as it goes through the glomerular capillary, we also have to make sure we balance plasma osmolarity while getting rid of toxins. And there are three processes in forming urine. The first is filtration, where blood flows through the glomerular capillary. The second is reabsorption. Remember, 99% of the water in the filtrate will be reabsorbed, as well as electrolytes, glucose, amino acids, other substances that we want to make sure we have so we can function. Those things can be reabsorbed from the tubules so they don't get flushed down the toilet. And when they're reabsorbed from the tubules, they'll go back into the bloodstream. And then we also have to secrete substances that we don't want, like nitrogenous waste products, including urea, ammonia, ammonium, uric acid, creatinine, maybe excess sodium, potassium, hydrogen, even calcium sometimes if there's too much calcium. Remember that if a person has low blood levels of calcium, then very likely parathyroid hormone will be acting on the kidneys to help them reabsorb more calcium. So there are so many control mechanisms that the body uses to make sure that we have the types of molecules that we need to perform our functions. There are other processes that occur that are assisted by the kidneys, including regulating blood pressure by way of the renin-angiotensin-aldosterone system, the production of erythrocytes through the hormone erythropoietin, activating vitamin D. The final step actually occurs in the kidneys. And if we look at this picture, you can also see that there are special cells called juxtaglomerular cells, and these guys are located next to the afferent arteriole. They're actually smooth muscle cells that help to control the pressure of blood flow in the afferent arteriole. You'll notice that there are special cells located here, and those are the macula-densa cells. They help monitor sodium concentration, and they can release signals also to help regulate blood flow. So the juxtaglomerular cells and the macula-densa make up something called the juxtaglomerular apparatus. Next, we're going to take a look at how the macula-densa and juxtaglomerular cells, which again form the juxtaglomerular apparatus, which is very commonly also known as the juxtaglomerular complex, work in concert with one another when blood pressure decreases. The macula-densa is able to sense changes in sodium ion concentration, and they can also sense low fluid flow. The juxtaglomerular cells are smooth muscle cells that act as mechanoreceptors, so they can detect changes in the pressure that's in the afferent arteriole. So if there is a decrease in blood pressure that's sensed by the juxtaglomerular complex cells, the macula-densa cells will actually send signals to the juxtaglomerular cells to secrete the hormone renin, which when it is released into the bloodstream will interact with a protein that normally circulates in the blood that's produced by the liver, known as angiotensinogen. When angiotensinogen interacts with renin, it will be converted into angiotensin 1. Angiotensin 1, when it reaches the lungs, is converted into angiotensin 2 by an enzyme that's found in pulmonary blood known as angiotensin converting enzyme. Angiotensin 2 will continue to circulate through the bloodstream, and it will cause widespread vasoconstriction. Well, remember, if we had a decrease in blood pressure that caused the release of renin, then vasoconstriction would help to raise blood pressure. And another thing that happens is the angiotensin 2, when it reaches the adrenal cortex, will cause the zona glomerulosa cells of the adrenal cortex to release aldosterone into the bloodstream. aldosterone will stimulate sodium reabsorption in the membranes of the distal convoluted tubule and the collecting ducts. And when sodium is reabsorbed, water follows, and that would increase fluid volume. If we're moving water out of the potential urine back into the body, that increases fluid volume, which helps increase fluid pressure. Remember that if blood volume drops or blood pressure drops, another thing that would probably happen is that the hypothalamus would detect that and send signals to the posterior pituitary to secrete antidiuretic hormone. And the action that antidiuretic hormone has is it actually causes aquaporins, which are protein channels that allow water to flow, and those aquaporins are going to be inserted on the plasma membranes of the cells of the collecting duct, which also helps increase water reabsorption. The hypothalamus would probably also cause the thirst response to be stimulated, so a person would be likely to drink if blood pressure falls and a person has low blood volume. When we look at the microscopic anatomy of the kidney tubules, we see that the proximal convoluted tubules, being made of simple cuboidal epithelium, have microvilli on their apical surface to increase surface area for reabsorption and secretion of different solutes. The loop of Henle has thick and thin portions and differing permeability on the ascending and descending portions. The distal convoluted tubule has less microvilli and less activity, therefore, than what is seen in the proximal convoluted tubule. And the epithelial cells of the distal convoluted tubule also have antidiuretic hormone receptors, so that when those are stimulated, again, they'll insert aquaporins for massive reabsorption of water. When we look at this picture, you can see that anything that's being reabsorbed is either to the left or the right or underneath the tubules in this picture, or in red. For anything that's being secreted, that would be above the tubules or in green. And I made a point to point out where the locations of these things are for anyone who is red-green colorblind. But as you look at this picture, you can see again, glucose, amino acids, water, salts, those are going to be reabsorbed in the proximal convoluted tubule, where drugs and poisons would be secreted from the proximal convoluted tubule. The descending limb of the loop of Henle is very permeable to water, so water gets out of the descending limb, whereas in the ascending limb of loop of Henle, it's impermeable to water, but salt exits at the ascending limb of the loop of Henle. If we continue on the distal convoluted tubule, you can see that salt can be reabsorbed, calcium can be reabsorbed, water can be reabsorbed, and the distal convoluted tubule is also where potassium and hydrogen ions and urea can be secreted. The collecting ducts are where water would be reabsorbed. So what a lot of people don't understand is hydrogen ions can be secreted. Hydrogen ions are how we look at levels of acidity. So for people who want to drink high pH water, the kidneys and the lungs and our buffer systems really balance pH in our body. So somebody's making a lot of money off of high pH water. There's really no reason to consume it. Remember that the first part of urine formation is the filtration of blood. The three processes are filtration, reabsorption, and secretion. So we know that blood is going to be filtered across the membranes of the glomerular capillaries due to net filtration pressure. And the rate of filtration is what we refer to as glomerular filtration rate. It's the volume of filtrate formed by both kidneys per minute. And it's influenced by competing pressures. As blood flows through the capillaries, red blood cells, white blood cells, and large proteins can't leave those fenestrated capillaries. And if we look at the forces involved in pressure, we have an outward pressure that you can see in this picture here, the arrow going out into the capsular space is that outward pressure formed by just blood pressure, blood hydrostatic pressure, which is the same as capillary hydrostatic pressure. We see that that is measured at 55 millimeters of mercury. However, the formed elements of blood and proteins in blood that are too large to leave the capillary are going to produce a back pressure known as blood colloid osmotic pressure. And so we can see that that pressure is 30 millimeters of mercury. So we've got 55 going out, 30 going back in. And then there's capsular hydrostatic pressure because the fluid in the capsule itself is going to form a back force for fluid coming into the capsule. And that pressure is measured at 15 millimeters of mercury. So after we take the outward pressure of 55 and subtract the 30 and 15 from that, we get a net outward pressure moving fluid into the proximal convoluted tubule that turns out to be 10 millimeters of mercury. And that's how filtration occurs, because the net pressure is the driving force. When it comes to tubular reabsorption, remember that approximately 180 liters a day are passing through nephrons. Most of the reabsorption is going to occur in the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then less in the collecting ducts. Different sections of the nephron have different permeabilities. They're tightly regulated by antidiuretic hormone, aldosterone, and renin. When filtrate is produced, the composition is usually water, sodium chloride, bicarbonate ions, hydrogen ions, urea, glucose, amino acids, and some drugs. In terms of the proximal convoluted tubule, that's where we're going to secrete some of the drugs and poisons. And we can also secrete hydrogen ions. We said that we secreted those in the distal convoluted tubule. They can also be secreted into the urine in the proximal convoluted tubule as well. So those are going to be secreted from the body into the potential urine. Okay, we want to get rid of the drugs and poisons and excess hydrogen ions. So proximal convoluted tubule will reabsorb nutrients, sodium chloride, water, bicarbonate. The loop of Henle is where we see reabsorption of water in the descending limb, salt in the ascending limb, and then the distal convoluted tubule, we can secrete more hydrogen ions as well as excess potassium. We can also reabsorb sodium chloride, water, and bicarbonate. And then in the collecting ducts, we can reabsorb salt and water and even urea if necessary. There are different mechanisms of recovery for tubular reabsorption to occur. Those include active transport, simple diffusion, and facilitated diffusion. Facilitated diffusion requires either membrane receptors or channel proteins for it to work. In facilitated diffusion, when two or more substances are moving in the same direction, we call that symport. Antiport is when two or more substances are moving in different directions using that same protein. And secondary active transport uses a concentration gradient created by active transport to drive the transport of other molecules through. This ends this particular video presentation. We're going to go on to part 2 of 2 next. See you then.